start first and then I give it to Saima and Hamad. So Assalamu alaikum everyone. Welcome to the 12th session of HIV Awareness, Prevention and Education Project in Pakistan, designed and led by APPNA-MERIT HIV Committee. This project aims to reduce HIV stigma, increase HIV awareness, and increase knowledge about the disease among the healthcare providers in Pakistan using educational and research tools. Please note, this is an academic volunteer activity, and all views expressed in these webinars are speakers' personal views and do not reflect any institution. During this calendar year, our team delivered 11 HIV educational webinars. More than 700 people participated in them, and webinar presenting faculty was affiliated with more than 35 institutions from the USA and Pakistan. Based on the information gathered in these 11 webinars, we published a report on World AIDS Day 2021. So this report summarized the pertinent issues raised by the healthcare community and strongly advocates for immediate and urgent attention to address the deadly trajectory of HIV in Pakistan. We are already planning our next year's project. And just in summary, our 2022 project is to help improve service delivery and quality of care provided at ART centers through collaborations and education of everyone involved. So to achieve this purpose, we have invited our panel who are all on front lines of HIV epidemic in Pakistan. Thank you all for joining today, and we dedicate this session to World AIDS Day 2021. So let's begin. Our moderator today are Dr. Saima Abbas and Dr. Hamad Ali. Dr. Abbas is an ID doctor, physician working in the USA and is the co-chair of APPNA-MERIT HIV Committee. And Dr. Hamad Ali is a medical epidemiologist currently working in USA. In 2019, he worked as a part of WHO team that investigated and responded to the HIV outbreak in children in Larkana. So welcome Dr. Abbas and Dr. Hamad Ali. You can start.
Thank you so much, Fiza, for the introduction. Bismillahirrahmanirrahim. Assalamu alaikum, everyone, and welcome to the APPNA-MERIT final webinar. Let me share my screen. Everybody can see?
Yes, we can see.
Okay, 1 second. Okay, chale. Thank you, Fiza, and thank you everyone else, and thank you, Hamad, for helping me with this moderation as well. And I am especially excited today to welcome our esteemed panelists who have the privilege of being in a position of power, influence, and authority, and have the funding without which any vision and any conversion of that vision into reality is near impossible. So we are very excited to have our leadership here today. So this is our final webinar, and the title is Vision for HIV in Pakistan for 2022. So as Fiza mentioned, this is our 6-page report that we submitted on the World AIDS Day HIV Awareness, Prevention and Education Project in Pakistan, basically summarizing what we did with the previous 11 webinars and what were our findings. And most of the discussion today is based on this. And if you have reviewed it, then most of those same issues will be discussed, inshallah. So in the interim, since we last presented that World AIDS Day, this is an interesting document that came to my attention, which I thought was again, important to share the ground reality as it is today. So apparently this is from the World Health Organization, the Sexual and Reproductive Health and Rights Infographic Snapshot of Pakistan 2021. Now, if you look at these statistics on this side here, these are basically based on UNAIDS estimates from 2019. So they're not depictive of today, but the most latest statistics that we have. So I'm just going to review the basic overall numbers. So the total number of new HIV infections is 25,000 as per 2019 UNAIDS estimates. The number of people living with HIV in Pakistan is estimated to be 190,000. And the number of AIDS-related deaths is about 6,800. Now, from an infectious disease standpoint, if these 190,000 individuals or more that we not know of do not get treatment or are not virologically suppressed, then this is 100% mortality in a decade or so, unless they die of other causes. So this is an important difference between any other virus that we talk about, that HIV is a slow killer and it will kill 100% of the time untreated, maybe 99.9% of the time untreated with HIV AIDS in a decade or so. So we've talked a lot about and heard the slogan of 90-90-90 and a more ambitious slogan of 95-95-95 testing and treatment cascade. So this is an important statistic that we need to be aware of as we discuss our vision today. So the first here column that you see is people living with HIV who know their status in Pakistan. So as you can see, the red circle means that there are major challenges here. An orange circle would mean that challenges remain, and a green circle would mean that the targets have been achieved. So this is definitely in the red. So only 12% of people living with HIV are estimated to know their HIV status as far as females, and 24% males. What does that mean? What that basically means is that at least 78 to 80% do not even know that they have HIV. The second column is that people living with HIV who know their status, who are on antiretroviral therapy, is only 9% of these people of the 12% and 13% of the 24%. So these are the patients who know they have HIV and they are getting treated for it. Now, the last column, which we do not have any data, that's what the no data ND stands for. So these are people living with HIV on antiretroviral therapy who have achieved viral load suppression. So unfortunately, we do not have any reliable and accurate statistics, at least not that have been published as yet. So what is the bottom line as we try to create a vision? So unlike COVID-19, where a vaccine is the most effective prevention, for HIV, treatment is the most effective prevention. So, we are already struggling with social distancing, masking, hand hygiene, and despite all those measures, we still end up with COVID. As far as HIV is concerned, whether it's condoms or abstinence from sex or reusing needle, monitoring that and preventing that, the bottom line is if they can take their medication and they are virologically suppressed, undetectable means untransmissible. So if we don't remember anything from today, the main vision is to test and treat. That is really the bottom line. So using the previous slide, these are the key performance indicators which we look at, which are important as the healthcare community to be aware of what are we really trying to do. So if you look at the first indicator, percentage of people newly diagnosed with HIV who know their HIV status is one very important vision that we need to increase our testing and screening. The second one is percentage of people living with HIV who know their HIV status, who are on antiretroviral treatment. And these are those who are registered at our 49 ART centers. And the third one is the percentage of people living with HIV who are on antiretroviral therapy and are actually virologically suppressed. And the last statistic, which I thought is important, although mortality statistics is difficult in Pakistan, but this is the number of AIDS-related deaths. So this is the last authentic document that is part of the HIV statistics and an in-depth analysis, which is the integrated biological behavioral surveillance, which was done in 2016 and 2017. And I think this is a quote that I took from there, which will be helpful in seeing where we are today, especially with our panelists. So the AIDS response must become substantially stronger, more strategic, and better coordinated, with accountability and transparency centered to it. It requires a strong national commitment and leadership at both the national, provincial, and sub-provincial levels. In addition, it needs a paradigm shift from an episodic crisis management approach to a long-term strategic response. So we are not here to reinvent the wheel. I think the vision in 2016 remains the same in 2021. So let's begin. I would like to invite our first speaker, which is Dr. Hina Javed, who's actually in the United Kingdom as of a few hours ago. And she will be helping us identify the knowledge, attitude, and practice gaps. She is actually a family practice physician, family medicine at University of Health Sciences in Lahore, and has participated in our previous brainstorming session, which was our 10th webinar. So welcome, Hina, and go ahead.
Thank you very much.
May I request a slight change in the program, because Dr. Nosheen Hamid is here, and she has another engagement as well. So if I can request a change in plan, Hina, if you don't mind.
That's fine. Yeah, please go.
Hamid to go first.
Yeah,
Okay.
welcome Dr. Nosheen Hamid.
Okay, let me.
Thank you so much.
Assalamu alaikum.
Thank you so much, and I'm so sorry for disrupting your sequence. Actually, it's a Sunday night in Pakistan. There were some commitments. So if you allow me, I could give my comments.
Okay, sure. Go ahead.
Thank you very much. So it's a real pleasure to be here amongst you, and you have taken up such an important topic, which is very, I think, relevant for Pakistan at the time. So I would like to congratulate the APPNA-MERIT HIV Committee and their collaborators on successfully conducting a year-long campaign on HIV awareness, prevention, and education in Pakistan. The current state of HIV control is worrisome. Pakistan has been registering 20,000 new HIV cases every year for the past few years. Case count among the countries. In Pakistan, did high-risk key populations for more than 30 years. Transmission is no longer confined to the key populations, which is really alarming for us. In the last decade, at least 5 out of 7 outbreaks of HIV in Pakistan have occurred in children, as well as men and women without traditional high-risk behaviors. So general population is getting infected, primarily because of the unregulated use of contaminated needles and syringes and the unscreened blood products. Hemodialysis units may also be contributing to the challenge is the communication. Data collection leaves a lot to be desired and leads to delay in the vital decisions and implementation of the control strategies. Our government is committed to provide better healthcare to the people of Pakistan through regulation of health systems to provide safe services. We have taken the essential first step towards preventing HIV, HPV, and HCV. transmission from used syringes. Our government has passed a legislation whereby only auto-destruct syringes will be used and they will be available for the medical use. Government is also trying to find ways to reduce our dependence on the foreign funding for control of diseases like TB, HIV, and malaria. One important step in introduction of universal healthcare, where screening for HIV would be important component and needs to be assured. Government is cognizant of the fact that the marginalized populations may not be getting the care they deserve. We are taking active steps toward facilitating key populations and transgenders and are planning to link them to the Sehat Sahulat in Health Insurance Program to provide the stigma-free care. We are grateful to the Global Fund for providing the grants and supporting the infrastructure for the HIV diagnostics and treatment services in Pakistan. We are also grateful to UNAIDS, UNDP, and WHO for their support. And we really hope that in the coming years, we will have some concrete steps to control the HIV, which I believe is a time bomb which Pakistan is sitting on. Thank you very much. And I will be with you. I will be hearing you. I will stay online and I would like to hear what you people are saying. Thank you very much for giving me the chance.
Thank you so much, Dr. Nosheen Hamid, and thank you so much for being here, despite how busy you are. And thank you so much for your comments. So we appreciate that auto-destruct syringes. That seems a very important step, and I hope that the implementation is not a frustrating journey, because like all policies, this has been an ongoing frustration with the healthcare community, that policies are made, but somehow there is an issue with implementation and execution. One question I had was, what is the level of acceptance of HIV in the parliament? Is that something which is still very stigmatized?
Yeah, I think in the parliament, in every session, we do have a question raised about HIV, because obviously that means the members are well aware of this situation, because every session they do talk about HIV, and because we have got a question hour in every session, this matter is taken up, and they are really interested to know what the government is doing, and the members even in the standing committees also and on the floor of the parliament, HIV is being talked about. That means that they are sensitized and they want to do something about it, and they know that obviously they don't consider it as a stigma. They want to know the solutions to it now, what the government is planning.
Okay, well, we appreciate your help, and you are in a position of power, and may Allah help you help all these people who are very helpless. So thank you for your time. I think we'll move on to Hina Javed. Yes, Dr. Hina, please go ahead.
Assalamu alaikum. Thank you very much for giving me this opportunity. And I'm glad that Madam ने एक outline provide कर दी है. Madam, I know you've mentioned, you've used the word sensitization and stuff. Lekin I think we need to be aware of the fact that denialism occurs at multiple levels. Denialism starting from those who have to make decisions, moving on to those who have to treat the patients. I belong to the family medicine fraternity. वहाँ पे paucity है training की, जो community based physician है उसकी, general practitioners जो privately based हैं उनकी हैं. How confident are we that our physicians sitting in the community are going to identify the high risk population, and how confident are they in asking the sensitive questions about somebody's lifestyle? It's a sensitive matter. You have to approach it in a particular way. तो क्या हमारे doctors की training वहाँ पर है या नहीं है? And are doctors in their comfort zone in bringing these matters up? कई दफ़ा हम suspect भी कर रहे होते हैं, but and then are there any helplines provided by the government कि जी अगर आप suspect कर रहे हैं, so can that be provided to the patient? You can call on this helpline and ask for confidentiality. क्या maintain होगी patient की? ये basic questions हैं. Madam, mental health problem में एक condition है depression. उसको हम social taboo ले लेते हैं. तो HIV AIDS की diagnosis देना उससे बहुत बड़ा level है. So these are some of the questions we need to start talking about. Yeah. और डॉक्टर्स की अप्रोच भी नॉन जजमेंटल होगी, बिकॉज नोबडी इज गोइंग टू टॉक अबाउट इट. यू फॉरगेट कि पेशेंट आपको कोई भी ऐसी इंफॉर्मेशन शेयर करेगा अपनी लाइफस्टाइल के बारे में, particularly high risk practices population. We know what these are. 3 outbreaks हुए हैं और उसमें we know the topmost cause, the evidence exists, it has been published in the literature by prominent people and internationally recognized, reuse of needles. So we know the cause. The question is, what actually are we planning to do about it? Again, we know the hotspots, we know the mechanism, how the reuse needle is used again, and so on and so forth. And am I right in thinking that denialism is accompanied by lack of empathy, again at multiple levels? There are several layers. Let's accept that there's a problem, and let's accept that we have to talk about it. So these are some of the things, the core issues which I wanted to just highlight. Believe me, it's not easy to have a conversation with the patient about this topic. Those who are, that's the ground reality basically. So I just would like you to just take that message back and kind of let's have a plan on how we can execute it. Thank you.
Thank you so much, Hina. I appreciate those. I always love your feedback. A couple things I would like to say is, we have talked about this in our previous webinars as well, is that making HIV a routine test without really going into the sensitive histories is something that we will have to come to. Number one. Number two, another thing is that, the perception of this disease has to be destigmatized because, you've had a blood transfusion, you went to the dentist, you went to the barber, now HIV is spreading. So it's spreading through syringes. Let me just do a routine test, not make a big deal of it. So these are some of the strategies that we use, but you are so right that if there is any hesitancy on the part of healthcare workers, of course, they're going to hesitate to even ask the question. So thank you very much, Hina.
I just want to add a quick point here. You cannot test a patient without their consent.
Yes.
If it comes back positive, it will have huge implications. We have to have these difficult, challenging consultations before the blood test. What if it comes back positive?
Yes.
That changes the whole thing. The relationship.
That's true.
So, yeah.
That is true. That is true. Well, I guess it's patient to patient based. And that you can, gauge. But I guess that is definitely an area of education and training. And I also appreciate your point about the helpline. I think that is a great point. Thank you so much, Hina. Thank you. Our next, I would like to invite our next speaker, Dr. Umair Malik. He is the HIV treatment specialist working in the PR unit of Global Fund National AIDS Control Program in Islamabad. And Dr. Umair, some words of wisdom on the topic today, and what is your vision and what are the gaps in achieving that?
Thank you very much. First of all, I would like to clarify two small things. One, that I'm working currently in SR unit. We are no more PR. The PR is UNDP, maybe Dr. Nashmiya is here. So the second thing is that you have shared the WHO slide, I think, which is very useful, but it is not capturing the viral load suppression in Pakistan. As the data comes to me and Dr. Bhushra knows, we have outsourced the viral load to AKU. So all the Pakistanis are eligible to go to any pickup point across Pakistan from GB, FATA, AJK. So the last I have with me, the exact data is 66% viral suppression. So we are on the track. We are struggling very hard, but this I have the evidence of this, that the last December 2020, I'm expecting it will be around 75 this year, but we are working very hard on this. Regarding your question, I just want to a few points. First of all, today I have discussed with some few outstanding counselors and the case managers in the field, and we have like FDD today. I asked them to give their feedback, and I'm just acknowledging them. Most of the people in the field are saying that the stigma is the single most cause of this lack of adherence. Because I've already shared with you the Dr. Nashmia, me, and Mr. David from US. We have studied that the patient who came to ART center and they are lost within the first visit. So I try to go the deeper, and the commonest perception from the field is that the stigma of the healthcare providers. This means that our ART centers are not customized to cater the needs of the people living with HIV/AIDS, and especially the key populations. So we need to look into it. How can we make the conducive environment? Because once the patient is in the clinic, we must work very hard, and a counseling should be so. The second thing is that the stigma and the behavior of the society. You know, when somebody declares HIV, if he's on the treatment, he may lose his job. There's the issue of divorce in the family. These are the issues. And third, the issue which is coming from the field is that the cost of the traveling cost, because we have 50 clinics in 33 districts, and Pakistan is a huge country. Currently, I have no clinic in whole merged districts of FATA, in JB and AJK. So the people from the Gilgit have to come to Islamabad, which is 14 to 18 hours by road. And this is, it just cost them the travel cost, because this is lifelong treatment. So we need to plan, and I think the Sindh government and Punjab government have already planned the next 2 to 3 years. In every DHQ, at every district level, we must have an HIV clinic across Pakistan. Another very interesting finding from the field was that the Aga Khan, or the result of viral load, when it says non-detective, the patient asks the healthcare providers nearest to their facility, like general physicians, and those who are not sensitized, that don't know the viral load non-detective means what, they wrongly inform or misinterpretation of the report that you are no more HIV positive. So this is very interesting from what I found from the field. Another thing is that we have the position of counselors in the field, but we don't have the female counselors or male counselors, and our patients are about 70% males. So we need look into our gender and cultural background, that maybe a female patient is not comfortable to talk to a male about the sexual rights, or a male counselor other way around. And another thing is that we have many overseas clients working in Middle East or UK or US. They are registered here, but when they go abroad, the system shows them lost to follow. We don't know whether they are getting treatment in Saudi Arabia, in UAE or US or America, but in our record, they are lost to follow. Another reason from the field was that the data is updated by the data entry operator, and like one of the big centers in Peshawar have no data entry operator. So there are 600 missing entries. So these patients are not lost to follow, but the record is showing them lost to follow. So another issue is that Punjab is not updating any data since last 5 years in national MIS. So any patient from Dow Medical College is transferred to Punjab, and because Punjab is not updating its data, is shown as lost to follow. Actually, because these people, they got jobs, they transfer from one district to another. Anybody is coming from KP, Balochistan and Sindh to Punjab is shown as lost to follow, because the Punjab is not updating the MIS. I think these are the major issues, plus the mechanism of reporting of death. Many lost to follow are actually dead, but there is no formal mechanism unless and until the relative informs the HIV ART clinic that the patient has been dead. Our records is always referring them that these are lost to follow. I think it is the time is enough for me. Thank you very much.
Thank you very much, Dr. Omer, for excellent suggestions and from feedback from your social workers. I think these sound like some, some data entry issues and some logistics, which I think we can ask our coming speakers. But excellent observations, Dr. Omer. Thank you. Is Dr. Khudadad Khan with us, or Fiza?
I don't see him. No.
I don't see him.
I don't think
I
so.
saw him for a minute, but I think maybe he's having some Wi-Fi issues. So we can move on. If he joins, we can go back to him.
Okay, I will hand over to Dr. Hamad.
Thank you, Saima. So since Dr. Khan is actually not on the line with us right now, we will move on to our next panelist, Dr. Faisal Mahmoud. Dr. Faisal Mahmoud is an associate professor at Aga Khan University and is the section head of infectious diseases. He has been working with HIV patients in Sindh for a very long time. Welcome, Faisal. And the question that I have for you is, since you've been working on the front lines for a long time with the patients, what are some of the greatest challenges that you see in patient care specifically, both in public and in the private sector? And what are some of the recommendations that you have to address those challenges?
Thank you, Ahmad, and thank you so much, APPNA, for inviting me. So I must say that I didn't know the question to begin with, so it's been a little bit of a surprise. But no, we can answer. So actually, the challenges in the private, public, both sectors, and a lot of these have already been mentioned, and Dr. Mayer very nicely put these together. And some of the really topical ones or things that we really never expected are, for example, the viral load one, which is something which has come up many times where people have actually been lost to follow-up just because the report says viral load not detected. And this is something that people have come to us multiple times asking us to fix the report or not say that the viral load is undetectable somehow. The biggest problem actually does depend on which group you're talking about. So if you talk about the IV drug users, the biggest issue we have over there is obviously retention in care. This is a very mobile population, a population which is lost to follow very frequently. And also, this is a population where we know that a lot of times therapy started, stopped, and transmission occurs very rapidly, which means that we are potentially sitting on a lot of drug-resistant HIV. And since genotyping or checking of resistance is not part of general care, this is sort of a challenge that we really do face. The second issue is with the MSMs. So with MSMs, for people who may not know, and I think a lot of us know, that MSMs in Pakistan, again, are a very heterogeneous group. We have our MSWs, male sex workers, which are sort of different than the other MSMs. And a lot of our men who have sex with men are actually part of the general population for the most part. They're married, they have children, but they also have this other life that they lead at the same time. And what we found when we've looked at centers is that a lot of people, when they come in and you look at the mode of transmission, it sort of says unknown or not documented. And we're currently sort of going back to some of these centers right now, currently trying to figure out, is it truly unknown, or was this something that you could not elicit in clinic? Again, something that Dr. Hina had brought up when you're taking a history and trying to elicit this out. The stigma is a big issue. And one problem we have with our HIV care in the country is that this is really at HIV care centers. So anybody walking in to one of these centers is sort of marked as somebody who has HIV. And this is why sort of a more combined clinic may work better. For example, this is what we have at AKU. My patients don't know who has HIV and who doesn't. And therefore, we have people coming from all over the country just for that one reason that people don't know that they have HIV. And the last challenge that I feel really is the care provision themselves. So over here, we have a lot of people who've been taking care of HIV for a long time. But if you go to the HIV centers, the training of the care providers is minimal, sometimes none. The way that they trained is by going to sort of shadowing another person who's often not an ID physician. And this is a job which nobody wants to do. Nobody wants to take care of HIV patients. So you can't really think of HIV as a career path very frequently. Once we had started, we tried to sort of make this a course where you could get almost like a degree in HIV, and there was just no interest. Nobody wanted to do this as a career. It's sort of not a great career. And I think I just saw Dr. Katie Usmani join in, and he left again, and he's probably been in the field for very long, and he also echoed something similar recently. So these are some of the challenges that I've seen, and I'm happy to talk later on. Thanks.
Thanks a lot, Faisal. We will certainly be talking about some of these challenges that you've highlighted with other panelists as well, but it's really, so the first challenge that you mentioned is really important, just the stigma of going to a clinic that is designated as an HIV clinic. And by proxy, even if you're going with somebody else, if you're taking a patient that that is potentially HIV positive, the stigma around that, the fact that you're actually going to the center automatically translates to you having HIV is obviously a big thing that needs to be addressed. But in interest of time, I'll move on to our next speaker, Dr. Ajwal Khan. Dr. Ajwal has worked with the government of Pakistan, with UNICEF and WHO, and is currently working with UNAIDS as the Strategic Information Advisor. Dr. Khan, there has been a lot of discussion in our previous webinars on failures of strategies, potentially because of either weak implementation, or because of poor accountability, or because of lack of transparency. As the SI advisor, what do you perceive as the most effective strategy to first evaluate the burden of disease in both key populations and general population? And also, what do you recommend as alternate strategies compared to what we have had in Pakistan so far?
No, thank you very much. You have very rightly pointed out that one of the main issues is the implementation of the strategies in rare spirit. I think the strategies that has been developed at the national level and the provincial level are neither being used to design or the govern, oversee and manage the AIDS control program at both the level, at the provincial level and the national level. Now, I think we need to look into this, but the serious issues is no doubt with the governance and accountability in the system. Now, I think Dr. Noshin Hamid is also on the line. And I think if some of these issues that the strategies developed by the government are implemented and in the spirit that I think will resolve all the issues, because the government is also now quite extent realizing that the intervention should be focused and targeted among the population where the highest burden of the disease is. Now, I think the only thing is to push for the implementation of the strategies that are developed through a broader consultative processes.
So my next question after that is, as the SI advisor, how confident are you in the data that is currently available to assess the burden of disease? We do have obviously a fair bit of data for key populations, but what about general population?
No, with the general population, we cannot say, because the only data that is available with us is either from the integrated biological behavior and biological services or extrapolated.
Dr. Khan, you're breaking up a little. Dr. Khan, we are unable to hear you if you're speaking. Okay, well, in interest of time, we'll move on to our next panelist and come back to Dr. Khan later if the connectivity improves. So our next speaker is Mr. Salman Qureshi, who is a senior program manager at Nayi Zindagi. Nayi Zindagi is a non-profit organization and provides health and social services to individuals and families affected by drug use and HIV/AIDS in Pakistan.
Yes.
Sorry, Dr. Khan, we actually lost you for a couple of minutes. Are you there?
Yeah, I am here. Yeah, please. No, I think the last question which I says that we do have the data, outdated information, but the next round of the IBBC is planned in early 2022. Now, hopefully with that, we will be having some more information and new data. But the challenge what we have is that the data is not used for the proper planning and decision makings. Over to you, please.
Thank you for that. And I actually also, our next speaker were Mr. Salman Qureshi, but I don't think I see him on the call anymore.
Yes,
Simon,
I don't see him too,
yeah.
so I think we can move on to our next speaker.
Sure. Simon, back to you.
Thank you, Hamad. Our next speaker is Dr. Ramesh Kumar. He is currently working with the Common Management Unit for HIV/AIDS, TB, Malaria, Global Fund Grant, Ministry of National Health Services, Regulations and Coordination. Dr. Kumar, I wanted to know what is the vision of the Ministry of National Health Services as far as estimating this burden of disease is concerned, and how do we plan to improve coordination and reporting of data at the national, provincial and sub-provincial level? What are your thoughts on that?
Thank you very much. Thank you very much for invitation, and thank you very much for arranging this nice forum to share our views regarding the vision of HIV, how we have to manage this HIV issues in Pakistan. Yes, regarding your question, as Madam Noshin Hamad has already mentioned about the vision of Ministry of Health, but I have to add few things. These are very important. So let me respond your first question. Regarding the leadership, yes, we do have big challenge nowadays, as we are seriously, facing this bigger problem regarding, IBPS data. If we see the number of new cases is going to rise within, if we see the last decade, there is a huge increase in number of infection in key population. Yes, so for that purpose, ministry should have a, I am confident that ministry is on it, and we are, the ministry is working on it and how to tackle this problem. And we need, definitely we need the support from our partners, and Global Fund, UNAIDS, and UNICEF and other partners. They all are on board, and we all are working together on these issues. So the main problem, as already a few panelists have mentioned about the testing and treating. So the testing and treating, government is on it, and we are well aware of it. Recently, we are going to establish 3 more new treatment centers in federal area, Gilgit, GB, and AJK. So these 3 different new centers is also going to be started very soon. So that will definitely tackle more key population to get a proper treatment in these centers. In addition to that, we are also facing a problem of coordination. We have a lot of issues regarding coordination after decentralization. As Dr. Umair also mentioned about data sharing from Punjab province is again a big challenge for us. And as just I have to add one thing, that I have newly joined just 2 weeks before. So during this period, we have also interacted with provincial management, and I am confident that we will get the provincial health department from Punjab as well, and we will be, inshallah, we will be able to get data from them very soon. So this is your probably second question about the data sharing. Yes, we, National AIDS Control Program, this is our mandate. Though we are not a PR nowadays, but we are SR with UNDP, but in spite that, we have a national mandate, and this data sharing and data management, monitoring evolution, and just to provide the treatment and testing across the country is mostly our responsibility as a NSCP under the ministry, under the umbrella of Ministry of Health. So yes, recently we have a very good MIS system, and we are capturing the data all over the country except Punjab, but we are working on it. So soon we will be able to get data from Punjab as well. So we are also we have a strong surveillance mechanism as well, and we are also working on it. Yes, one of the speakers, Dr. Faisal, also mentioned about the training. The training is main component, and Dr. Umair is also mentioned about the stigma. Recently, last week we had a session in federal government hospitals where Dr. Umair has conducted a session for healthcare workers to control and to manage the stigma. There are a lot of, this is the main reason for their loss to follow up among the HIV patient. So we have to give more trainings all over the country, and I would request our partners to help NSCP and help provinces to to get on board, to train more doctors in this area. So these are the main responses from your question. If you have more question, then I can add on it. Thank you very much. Over to you.
Thank you so much, Dr. Kumar. I think you bring the very important point about training, especially for the ART center staff and all the counseling that is needed. And so I think one vision will be to take each ART center and provide them with targeted training. That's a great point. And since you've just started 2 weeks ago, first of all, welcome. And I think this is a good session to just, although you seem to be aware of the data issues, and I hope that the information system, MIS system that you said, especially in the setting of COVID, really works for HIV as well. I think Hina wants to say something. Did you?
I just want to add something to what Dr. Kumar has mentioned. Considering the gravity of the situation, training of ART staff would be insufficient. You need to go down to the ground level, i.e. involve the family physicians. I don't think we can win this game without including a community-based physician. And that's crucial. And I think it's important we understand this sooner rather than later. So my special request to Dr. Ramesh Kumar, please. Thank you.
And if I may intervene really quickly for a second, I also completely agree with that, because when we talk about HIV, generally a lot of focus goes on to the treatment and care of HIV patients. But we need to remember that the first 90 or the first 95 is as important as the treatment and care of HIV patients. So till we actually don't know how many people actually have HIV and then bring them to treatment and care, we are only doing half of the work that needs to be done.
Dr. Kumar, would you like to respond to Dr. Hina's comment?
Yes, Hina, thank you very much for the question. And you have rightly pointed out, and I have forgot to mention this important thing as well. Yes, to integrate HIV, program with primary healthcare in Pakistan. This is, our agenda nowadays, and even ministry is also working on it, especially for universal health coverage and DCP3 package. We are also trying to integrate this, HIV program with PHC. So this is yes, we are much aware and we are working on it. And very soon we will try to, integrate this HIV with our lady health worker program, national program, and even at grassroots level at the basic health unit. So yes, I mean, this may bring a lot of, changes if we will be success to get this program.
Sir, with all due respect, you will not be able to achieve universal health coverage without recognizing family physicians within the public sector, within the public sector institute.
Yes. Let me respond to your query. Yes, you are, family physician is backbone of health system in every, developing or developed country, whatever we can talk. Everywhere in the health system, the family physician are, pillar of the health system. Yes, I'm working in Health Services Academy as a professor in public health, and recently we have also started this family physician, and we are also going to train the doctors in family medicine as well. And this is, main area where we have to involve and we have to train GPs all over the country in Pakistan. So we are working on it in other aspect as well, and WHO, with the support of WHO and Ministry of Health and Health Services Academy, we are working on it. And definitely we will try to integrate this program, and we will try to involve GPs who are working at local community level, especially in rural areas. So yes, and second thing, just I have to add one more thing. Last week I met with some officials in ministry, where we are also, trying to include this HIV clinics with ID clinics all over the country. So I mean, this is our idea. So in future, we will try to integrate these HIV clinics with TB clinics, infectious disease clinics, and something like that. If you are talking about family medicine or family physician. So this is again on the higher agenda of ministry as well. Over to you.
Sir, आप एक family physician को treat कर दें, तो 3 family physician per 10,000 population आपको achievement, ये सारे vertical programs वहाँ पे merge कर जाएंगे. You cannot provide a specialist for every condition in the peripheral areas to the marginalized population. However, what is doable is you treat a family physician considering the burden of the diseases. You have all the stats, you have all the evidences, you've said family medicine is the backbone. It actually does need the backing of the government, which is lacking.
Yes, you are right. But recently, as I already mentioned, that government is, working on it, and we are trying to, involve all GPs, and we are trying to train more GPs in this program. So we have started this program in 2020 in Health Services Academy, and provinces, they are also trying to, start their own program in each province. So yes, you are rightly pointed out this issue, and we will try to integrate, and we will try to train these family physicians at grassroots level. That will bring a lot of changes in the system as well. Over to you. Thank you.
Thank you.
Dr. Ramesh, can we add something?
Yes, Dr. Khan.
I think what we can do, Dr. Nishma is already online. She can also have her own opinion. I think we can give her the opportunity on the family physician or the general practitioner involvement. But we would also suggest that Dr. Nishma, me, you and Hina Javed, we can sit sometime together and let's find the way how to involve the general physician, how to make a further programming for it. No, however, the Nishma will be discussing this more in detail.
Dr.
Thank
Rahman, I have a comment. Dr.
Thank you so
Muhammad.
much. Yes, Dr. Omer, you want to say something?
I have a very small comment. The discussion is very academic and very practical. What I have seen, the success story in Pakistan recently is COVID testing. Whenever any overseas Pakistanis from any airline, it's either a rapid testing, a private Chughtai lab, or Aga Khan, a public sector. Anybody is testing in Pakistan, the dashboard of NCOC will depict the condition and the government can decide about the fate, lockdown and vacations. What missing in HIV is that people are getting tested in private blood banks, public blood banks, private labs, public hospitals, GP clinics. It is rapid test and field. We are only capturing data which are testing is done at HIV clinic or RCBUs or RNZ, the Nayi Zindagi. We are not getting any data from anywhere. My suggestion is to Madam Nosheen is here and we can discuss with Dr. Faisal Sultan that our MIS is very robust, very good. We only want the private sector or the other people or partners who are doing any sort of HIV testing to share with us. We can reconfirm them. We can link the patient to the treatment. We can test the spouse and wives and their kids. So this is my humble suggestion. Thank you.
Thank you, Dr. Umer. I think one of the very important that we need a integrated, harmonized MIS system where all the private sector are supposed to be reporting. And I think one of the big challenge that Dr. Ramesh to take is to have integrated, harmonized MIS system of the HIV response in the country.
Thank you very much, Dr. Omer. That was a very important point. And I think I see a comment from Dr. Soumya Iqtidar, and she mentions that they're planning to start a training session for physicians through the Pakistan Society of Internal Medicine. And Soumya and Hina have been with us from the beginning. So I think this is the grassroots training, which I completely agree with this point and appreciate everyone, including our general practitioners, for pitching in. I think we need to take these questions to our next speaker, Dr. Nashmia Mahmood. She is a Fulbright scholar, medical doctor, and a public health specialist. She's currently working with UNDP as the National Program Specialist, and UNDP is now the primary recipient for the global funding. So Dr. Nashmia Mahmood, what is your vision to change this deadly trajectory that this HIV epidemic is on? And are we on track to achieve the 95-95-95 targets? And now that UNDP is a primary recipient, how do you propose to address these issues that have come up, especially in this discussion, and the unmet needs of the people living with HIV?
Thank you very much. I was waiting for my turn to respond to the GP and family physician question as well. I think much has been said, and thank you for a very good presentation. And it's a very good forum where we can actually discuss and talk with APPNA doctors as well. So I'm happy to be here. Yes, as part of UNDP, I would like to share that we have a component on just on the last point, because everybody was discussing. So we have a component where we will be engaging GPs and training the ART center staff, and engagement of family physicians and general practitioners is the key towards the achievement of these 95-95-95 goals. And looking at a holistic point, and since UNDP is the principal recipient of the grant, we have this huge task in front of us, and we are definitely delayed to meet the targets. And there has been discussion on the strategies and also the accountability mechanism. I think we have everything in place. We have the much effort was done into 2019 to develop these national and the provincial strategies, which are aligned with the international guidelines for HIV. And then it was a big exercise which was conducted all across the country with multiple partners and multiple stakeholders, taking everybody on board, and a lot of consultative meetings were held. And based on that, we also tried to incorporate the guidance from those strategies into the funding request. And I happen to be the national consultant for this Global Fund Grant proposal development as well. So I know that a lot of efforts have been done collectively from all partners, from public as well as the private sector. However, I think the main gap at our country level comes at the implementation. We know what to do, we know how it should be done. However, when we come to the actual practical implementation of those strategies, those guiding documents, even I would say many trainings have also been done. A lot of capacity development exercises have been conducted. I have been engaged with this epidemic for the past 20 years. And I know in the last 2 decades, many initiatives have been undertaken. However, when we come to the actual interest for the beneficiary and the final treatment or the final outcome, I would say, that's where we are compromised. We conducted this ART outcome study, and it's very sad to see that 1/3 of the people who are actually detected, diagnosed, tested positive, linked to the treatment centers, we lose 1/3. So that's such a low hanging fruit that you lose, that you lose those patients who are positive, you've been started on the treatment, and because of the stigma and discrimination and other issues as well, the treatment adherence issues as well, and psychological, and there are multiple issues. However, stigma and discrimination came out really significant from there, and we lose those patients. So I think we really need to roll up our sleeves and move towards achievement of these targets. Thank you.
Dr.
Saima, please unmute yourself.
Can I just make one comment in addition
Sure,
to
Hannah.
the lady who's just spoken? Unless and until you make people accountable, implementation नहीं हो सकेगी. Training करके आप out हो जाते हैं. आपने resource use किया है, उसकी utilization क्या है? Are we wasting the resource here? So the training on its own, यहाँ पे chat box में भी messages आएंगे, training offer कर रहे हैं. Fair enough, but you have to hold people accountable. कोई check, cross check है यहाँ पे? Are we missing that link?
You're very right. That's what I'm saying. कि जब आपकी implementation की बात आती है, when you actually come to see the doctor-patient relationship or the actual benefit to the patients and the people. Similarly, if you look at the key population and you see your outreach there, you have to do it through those communities, and you have to reach those communities through their networks. So there are many gaps when we are trying to reach them, and there are many gaps where we're trying to work through the CBOs. So that part also has to be strengthened. One component is through our healthcare providers, and then another component is to reach to the communities through these community-based organizations. So you're right, we have a lot of issues, and the main issue and challenge is with the implementation and accountability.
Yeah.
Thank you.
Is there, Dr. Mahmood, I'm not there, but just is there any like a neutral monitoring of any sort? I mean, the thing is, there's a little bit frustration as to who is actually taking ownership and responsibility. You know, there are definitely a lot of policies, but who is performing that role of accountability?
We have CCM, we have the country coordinating mechanism, and they're all the government, UN partners, and the donor organizations, the Association of People Living with HIV. They sit on that board, and they sit on that coordinating mechanism, and they have their quarterly meetings. They also go in the field. They also go to the ART centers and to the CBOs to actually see the work that is being done on the ground. So that mechanism is there, and they're quite strong in Pakistan. And then we have the missions coming in, and the Global Fund mission also coming in to see the services. So it's not that the accountability mechanism is not there, but yes, a lot is also needed to be done. But that mechanism is quite comprehensive. It includes all the significant partners and also the people who are suffering from the disease. So if you attend one of those meetings, even the community members are there, people who are suffering from the disease, from the 3 diseases, HIV, malaria, and tuberculosis. So not only the organizations and the key partners are there, the actual patients are also sitting on the table and questioning you.
Okay, well, we would love to have the CCM to our conversation and bring them here as well.
I just want to make a request. Please, all panelists, stay with us. We will try to finish this very soon, but please stay with us. Thank you very much.
Sure, thank you.
I think I'm going to move on to Dr. Bhushtra Jameel. She is the president of Medical Microbiology and Infectious Disease Society of Pakistan and is a professor and consultant infectious diseases at Aga Khan University. And thank you, Bhushra, from being here from day one. And Alhamdulillah, we are at the end of the final webinar, which has been, thanks for your help on that. So, you know, the main question of infection control policies, and there's so many, you know, issues that came up, so feel free to respond to those. But especially with infection control policies, especially with the iatrogenic shift in transmission, what is being done for that? And go ahead, thanks.
So thank you very much. This has been a very useful session and much needed one, because we need to have this open dialogue with all the stakeholders and everyone who's contributing to HIV control in Pakistan. So regarding infection prevention and control, so after the Ratodero outbreak, the world kind of descended on Pakistan and they took over the control. So people came in, teams came in, they took charge, took the entire responsibility of training people on ground, spent a few months here, and then wrapped up and went away. The result, as expected, was there was no impact on what was happening on the ground. So the practices remained the same, because whatever the activities which took place, I think they were not internalized and they were considered as something foreign, which was just being slapped on people who were there on the ground, and they did not adopt them. So the ground situation has actually not changed, despite many people coming in, spending a lot of money, making a lot of noise, making the problem visible, but no solution. The problem is still there. And Global Fund actually is cognizant of the fact that the situation has not improved and is quite worried. So when this opportunity came for COVID-19 mitigation funding, we actually purposely included infection prevention and control strategies within the grant, because that was an additional fund and nobody had asked for it in the HIV grant, which is very sad. So we developed a separate component for infection prevention and control to be implemented in the HIV hotspots in the country, because this is our opportunity to actually do some work in places where we know that HIV is an issue and the number of cases are increasing, despite everyone being aware that these are the places, problematic area, nothing concrete has happened on ground. So one strategy is implementing good infection prevention practices, providing them with means of appropriate waste disposal. So this is all built in, and that has been approved through our C19 mitigation grant response mechanism funding, which Pakistan has received. So we have the funds now. The next step is implementation and then monitoring. So the first step has been taken. We have the funds. We know the problem, we have the funds, we have the strategy. Now it has to be implemented. And I think I'm actually quite grateful to Global Fund, because I think the problem has been, what I've seen is that there has been no academic dialogue even with the Global Fund. So the people who understand the problems on the ground don't get the chance to talk to the funding agencies. That is one major issue. And this time round, we had long discussions with Global Fund, and we got a total funding of 90 million US dollars, which includes the infection prevention and control practices. And we've got whole genome sequencing funded as well. So we have focused on strengthening health systems, digitalization, IPC, and so on. So, and then linking Sehat Sahulat with marginalized populations. So just taking small steps, getting funding, whatever the source which is available easily. So, and this APPNA activity is a very important platform, because this is the first time we've had the opportunity to sit together, bring in people from different funding agencies, from implementers, policymakers, and this is a good opportunity to actually talk about the real issues and come up with strategies which can be funded and implemented and monitored.
Thank you very much, Bhushra. And I think that your point of academic dialogue and that lack of that can be very isolating for any physician who's treating HIV, if you don't have that constant engagement. So I think we are happy that at least this platform is definitely inviting engagement. One question, it was kind of new for me, is this concept of CCM. I'm not sure if we have missed them in our conversation, or can you tell me a little bit about that?
Yes, CCM is a committee, sort of a committee, country coordinating mechanism. So you have members from civil society, from donor agencies, from community-based organizations. They all come together, and whenever there's an application for a grant, you have to present it to the entire group and get their feedback and endorsement. So whatever the grant is approved by Global Fund, it has to be endorsed by CCM members. So you have this groups of individuals from different backgrounds. So some are subject experts, some are just members of civil society, lawyers, CBO members, etc. You are mute.
Sorry, is Dr. Rajwal Khan part of the CCM?
Yes, he is.
Okay.
Yes, UNAID is part of the CCM.
Okay, Dr. Khan, please go ahead. Tell us these gaps in...
Mainly the CCM is the body that regulate or coordinate all the activities of the Global Fund. As Dr. Bhushra has very rightly said, that all the proposal or all the fundings that are supposed to be approved by the Global Fund are to be endorsed by the CCM members. The CCM have 50 members from the government and 50% are from the private sector. In the 50% of the private sector, the UNAIDS, the DFID, are the permanent members from the development partners, and WHO is also a member. These four are from the private sector. The PRs are co-opted members, and the other association for people living with HIV is represented the community, one the transgender community, and one is from the malaria and the TB disease representatives are available. The civil society, a few civil societies are also member of that committee. Unfortunately, what the decisions are made over there, Dr. Bhushra have been witnessed that the government representative are usually not available or either least interested to attend. For example, in my whole 7 years experience, I have rarely seen the member of the Human Rights Ministry, rarely seen the member from the Planning Commission. No, like this, no, then definitely the decisions are made by in the interest of someone else.
So what is we need some hope, Dr. Khan. What is the next? How can we work with those who do? Mm-hmm.
No, I think what in my Dr. Nishma has already pointed out, I think we have to look into the organization of the CCM also, depending on what criteria is set. But however, in the next meeting, I think we can take up this matter that we have to restructure or reorganize the CCM membership, how to make it more effective.
Okay, that is great. We really wish you all the best with that. Yeah, and this is a big jihad, Dr. Khan. But so we are here to support and collaborate.
The basic challenge is that I think we don't have any such problem with the resources, because the provincial PC1s are appropriately or self-sufficient with the resources. The more than 3,000 million has been allocated in Punjab, 50 million in Khyber Pakhtunkhwa. Now, for example, 50 million in Balochistan, more than 246 million in Sindh for this one financial year. Now, I think we have a lot of resources, but the only thing is that the coordination among the provinces and the federal level, and then the real implementation issue, which my colleague Dr. Nishma has already pointed out. No, the strategies are there, the good practices, international practices are there, but the implementation is a real issue.
Yes, yeah, thank you so much.
Dr. Bhushra has also invest.
I think you're breaking up.
Results of at least number term is leading, and the thing is that the community-led responses are strengthening with every passing day.
Okay, very much, and we truly appreciate your comments, your suggestions, and your true hard work. So thank you so much. I think we have one other speaker, a panelist from Dr. Naheed Usmani. She is the immediate past president of APPNA and a founding member of the MERIT program. And we would like to hear some comments from her. Welcome, Dr. Usmani.
Thank you so much, Dr. Abbas, Dr. Fiza Gilani, Dr. Hamad Ali, and all the worthy panelists on this forum. I have found today's session to be so educational and so encouraging that all of you are frankly talking about the challenges, the issues confronting the HIV community in Pakistan, and are strategizing what are the next best steps and what are the challenges and how can we address them. And I think it's all a matter of conversation amongst yourselves, where Dr. Hina Javed is concerned. APPNA-MERIT started the Family Medicine Initiative, looking at the gaps in primary care across Pakistan, recognizing that it is one of the pillars of, it is the main pillar, actually, of medicine in any country. And this year-long session, educational and awareness session, organized by the HIV Committee of APPNA, highlights that it crosses, the primary care, the specialty care, and has impact at so many different levels. Even in US, we are struggling with lack of psychosocial support for our complex patients. And we realize that we have to have an interdisciplinary, a multidisciplinary approach to managing these complicated patients. And having a social worker and a psychologist is key to, having follow up and take away the stigmatization, and develop a collegial and a collaborative relationship with the patient and the family. I got sucked in HIV because I'm a pediatric hematologist oncologist. Being a pediatrician, when I heard about these cases in Sindh in pediatrics, it was very heartrending that children were contracting it, even though they are not historically, the typical patients who come down with HIV. And with the primary care, we also have to include pediatricians, etc., and education. And it is important that it becomes a nationwide, effort to eliminate HIV, or at least get everybody treated for this very treatable disease at this stage. Nobody dies of HIV nowadays, except in Pakistan. So we need to make sure that those treatments are available in Pakistan. I thank Dr. Fiza Gilani for inviting me. I hope this conversation will continue. Thank you so much.
Over to you, Hamad and Fiza. Do we have any questions? Thank you so much.
Thank you, Dr. Naid Usmani. And I will really thank you to recognize this platform like 15, 20 years ago. Dr. Naid Usmani is the founder of this MERIT program. And your vision for this platform, I think, is you must be very proud of this today. You created this platform for all of us. Thank you.
No, I'm very proud of being associated with all of you. I think कि ये talent तो आपका है. हमने तो एक प्लेटफॉर्म अपना ने प्रोवाइड किया है, लेकिन काम करने वाले तो आप सब हैं. और ये सारा शुक्रिया आप पे जाता है, सारा क्रेडिट आप लोगों को जाता है कि you're taking it to the next step. And I hope it doesn't stop with just this end of the year, that we continue the HIV work. It's an ongoing dialogue, is what I'm left with this final session. Okay, we have made a lot of progress, that we have all the players together talking about the disease and the challenges. So there's free communication. But then what we are going to do with those challenges, that has to be an ongoing dialogue. And I think one little step at a time, we're going to make a change.
Yes, thank you. And that is our actually next year's project, which relates to all of these points raised by our great panel today. And we'll continue. Thank you.
And that's precisely what I wanted to say at this stage, that just that this is not our final webinar. This is just our final webinar for the year. And this will obviously, the efforts will continue not just throughout next year, but in the future. And I did want to invite all our panelists that are on our call today for a session probably within 6 months or 12 months from today, just to come back and just so we can keep the conversation going. And this is hopefully not going to be the only session where you all get to participate and provide feedback and discuss different strengths, weaknesses, challenges, solutions. But we will certainly ensure that there are further sessions in the future as well, where we actually continue to have this dialogue.
I think Fauzia wants to say something. Yes, Fauzia.
Yes, Assalamu alaikum. Thank you. It has been a great session today, and I really appreciate all the speakers. I had one comment and one question for Ms. Mahmood, Nashmia Mahmood. So, I mean, really at this time, there is a lot of data coming in resource-rich settings like United States, that HIV testing and continuation of their care went down during the pandemic, especially in vulnerable populations. I can't even imagine like how things are in, resource challenge settings like in Pakistan among these populations. And definitely, this is great that we are talking about increasing HIV testing and upscaling it. I wanted to ask you, has there been any discussion about funding for pre-exposure prophylaxis, especially for the most vulnerable key populations in Pakistan? Because prevention is really the key. And that would be great if we can start this discussion as well.
Yes, thank you. I think that many efforts have been done in PrEP and also post-exposure prophylaxis. And we will be starting this PrEP. We had this initial training on that, and rollout will be started from the beginning of the year. And yes, COVID did had a toll on the people coming to the centers, people getting tested, and also for the treatment time period. Initially, they were getting 2 months medication, and now because of COVID, that duration has been extended. So we are trying to adjust with this new normal. And but for PrEP rollout, we have already started a lot of efforts, and the initiative will start from the Q1 of next year. Thank you.
Thank you. Yes, Ahmad.
So we do have a number of questions in our Q&A box. We will maybe start with some of these questions. Not sure how much time we'll have to address all the questions, but I'll start from the top and request our panelists to participate in the Q&A session. So the first question that we have is, can public education about needle reuse at local and national level, is it being done, and is it being supported by the Parliament?
Actually, can I add? WHO has worked a lot on injection safety issues with ministry, but I think we need to involve Dr. Pasha, who is looking after this. I am not the part of that group, but substantial work has been done, and the exact situation, because I'm not the part of that group. If the group allows me to during next meeting, we can invite Dr. Pasha, who's looking after hepatitis and HIV in WHO Pakistan.
Perhaps I can respond.
Please.
So, yeah. So again, WHO took lead in conducting sessions for safe injection use, but there has been no impact of such training. And WHO actually accepts failure in this regard. And because of this reason, it was thought necessary to just discontinue reusable syringes. And for IV drug users, Mr. Salman was supposed to be here, but I've seen their program as well. So they have a needle exchange program to ensure that the used needles are not used on other people, and to stem transmission of HIV from one IV drug user to another. So they have a well-established needle exchange program. And as far as government is concerned, the reusable syringes will not be available in the next few months. So only self-destructing solo use syringes will be available.
Great. Thank you both. Just in interest of time, moving to the second question that we have, and that is around the recent outbreak in Sindh. And the question is that, don't we think that HIV is already in the general population? And is the main issue regarding data and reporting, considering that there was recently a major outbreak in the general population itself?
Dr. Bhushra, are you responding, or should I?
It's up to you.
I am responding. Yeah, this Larkana outbreak, yes, it was really alarming, and many efforts have been done in that regard. And there are many pockets and there are many outbreaks which are indicative of that spillover in the general population. And even having that concentrated epidemic in the key population and more than 5% is also a threat where it can actually spill over in the general population. So we are also trying to have this Larkana review, which is going to be a joint initiative with UNAIDS and UNDP together with the government of Sindh to look into this, and also extend our services to go deep down at that level and explore what can be done to mitigate those things. But yes, we are very close to having that epidemic in general population.
Can I add, Dr. Sana?
Yes, sir.
I think Dr. Nashmiya is right, but there is another population which we called as bridging population. The wives of IDUs, they are getting infection from their husbands, the partners of sex workers and transgenders. So we have the bridging population where we are not actually catering, we are not screening. We need to increase our testing actually. And the other thing which I have already, the COVID model, the testing in the field in various stakeholders need to be captured at central MIS. There, because the testing is there, but we are not capturing that into the mainstream HIV data. Thank you.
So just a comment, the bridging population is an expected group that HIV will spill over into bridging population. Our problem is much more serious than that. It has spilled over into general population, which are not part of the bridging population. And the mode of transmission is not sexual transmission. There may be more than one modes of transmission. And there is a lot of interest and activity to control whatever is perceived as the precipitating factor. Then all the activities kind of just fizzle out. So this has been the pattern, and Larkana is not the only place where the disease has spilled into general population. The identified hotspots of HIV including Jalalpur, Jatta, and Sargodha, and other areas which have been identified, it has spilled over into general population.
Yes, and I think if Dr. Faisal is here, maybe he can comment on that as well.
Faisal Mahmoud is here. So yeah, and I did want to comment on that, apart from the known hotspots, I think one of Dr. K.D. Usmani's talks really brought to light that there are also many unknown hotspots, where in Balochistan now they're seeing a lot of general population people coming in who are not really true key populations. And I think this is all really boils down to what we've been saying, is Pakistan seems to be sort of a little slightly unique in the injection safety being one of the key risk factors here beyond sexual and IDUs.
One very small point, if you allow me. The program data which I have, the treatment is very interesting and it's not public yet. We have 31% PLHIVs on treatment who are IDUs. Only 1% belongs to so-called the MSM, FSW, and transgenders. The rest are all, at least they claim, from general population. So program data is, as Dr. Faisal said, that MSM and MSWs are not identifying them, but only IDUs and transgenders are identified. But it's the only 31% of IDUs which we are really confident they are key populations. So the program data shows that it is going into a general population. Yes.
So I'm actually really glad that this conversation led into this direction, because not just the three sort of hotspots that Bhushra mentioned, there have been a number of other outbreaks reported, whether they were reported by the media and never really investigated further, or there were some investigations by either the government or by academic partners. There has been certainly over the last 10 years at least, or probably a little bit more than that, number of outbreaks that have been reported in the general population across the country. And some of this information has now been published in the literature as well. So it's certainly the tip of the iceberg. If we are seeing these hotspots in different places across the country, then obviously there's a lot more going on that we haven't been able to investigate. And obviously part of lack of testing in the general population is obviously a factor that should be taken into consideration. So I'll just quickly go to one more question. I know we are over an hour and a half, but maybe we'll just keep going for a little bit more. The next question is, can televisits be provided where HIV clinics are not available, for example, in JFK and FATA areas?
Should I respond?
Sure.
We have, first of all, we have the budget, and we are planning very soon. In fact, I'm planning within a month to visit AJK and GB, where the initial work has been done by Dr. Bhushra, and one in Islamabad. But yes, the teleclinic, the COVID has shown the beauty of the telemedicine. and it is a part of this global fund proposal. I don't know what is the current, Dr. Nashmia can respond, but the initial proposal we suggested is to have a telemedicine clinic where, because one of the challenges that key population, they come to the clinic very late, 11 or 12, and our public hospitals, they work from 8 to 2. So the working hours for investigations very difficult. So we suggested from 10 to 5 or 11 to 5 with prolonged working hours. So I think this model should be a trial. And in COVID, we have a very successful model of telemedicine in Pakistan. Dr. Nashmia?
I just want to add, sorry, Umair, that Dr. Merke, I now, since COVID, have a number of my HIV patients who've actually moved to telemedicine and not to physical. Some of these are actually overseas. I have a few people from Dubai, for example, who are living there, and we consult on teleclinic, and they come in every 6 months. I have some people who are up north. Also, a number of people, because of stigma, again, have now preferred to move to telemedicine and are actually very happy with the model.
Thank you for your feedback, Dr. Faisal. Yes, I think moving to this telemedicine would be helpful for the continuation of the patients. I'm not sure how helpful and how successful it will be for initial engagement of the patient. So I think we have to keep that in mind when we model it. So I mean, that is in our plan, but the initial concept is to have it with the Islamabad level and then continue with telemedicine. Dr. Umair, correct me if there's something else in that.
Yes, what we have, I think what I remember in the proposal was one model clinic in Islamabad. The physician will be based at APPNA-MERIT HIV office.
Yes.
And then it will cater only the follow-up patients. You are right, not for initial patients, because then you need baseline CD4 and a lot of labs, the gene expert. So, but for follow-up patients who are stable, their viral load is non-detective, they may continue on telemedicine. Maybe Dr. Bhushtra can add.
Yes,
thank you.
Because we had put in a proposal for the COVID mitigation grant, and actually it can be linked to the entire digitalization component, which has been fully funded by the Global Fund. So the objective was to offer teleconsultation to patients who have non-HIV problems as well. So if there is a medical issue, they're hypertensive, or there is some other issue, they can, without actually coming to the center, should have this option of consulting a physician, a family physician, or a specialist. So that was the objective behind it. And secondly, again, because of lockdowns due to COVID, to provide this option of consultation to HIV patients, and again, follow-up HIV patients, not the initial ones. So this can be linked to the digitalization strategy, but it depends on who will be implementing the digitalization component, because it can be easily linked to teleconsultation.
So one thing that Soumya brought up that is probably going to be linked to the teleconsultations or for HIV patients is, what about the availability of ART in the outside the government sector? So if we do have telemedicine available, then people will still need to go and collect their medicine somewhere. And if the medicines are once again only available at the ART center, then we are back to the same problem that we started off with, that people still have to visit the ART center. So could you please talk about that?
So definitely there needs to be a dialogue on implementation. At the moment, we are kind of created a wall around ourselves, and we just insist on talking about ART centers. And that's not the way to handle the problem, because it is highly stigmatizing. So there should be a dialogue between whosoever is looking after family medicine services, the universal health coverage, and linking these facilities with pharmacies, which can provide not just ART, but anti-tuberculous medicines and other drugs which are provided free of cost to patients. And here comes the concept of one-stop shop. So you have one center providing services for multiple diseases. And we proposed this in the COVID mitigation grant as well. And it all depends on whoever is going to implement it.
The other way to do this is to do a DSD model, which we've also been working on, where once somebody's stabilized from wherever they get the care, ART center, for example, they can, for drug pickup, they just go to their local BHU or THQ, not an ART center, just for drug pickup, because this is a lifelong sort of a disease, and you don't want people to travel far away, and they can just go to the local center just for drug pickup. And those people are then obviously trained, and these are obviously family physicians, on monitoring for any complications, etc., and then referring back only if required when they need to. So a DSD model also would work very well in this particular situation.
I don't know about the other disease.
Add to what Dr. Faisal has said, that will streamline the referral system between the primary care and the secondary care, and they'll probably start talking to each other as well. Just out of curiosity, Dr. Bhushtra Jameel mentioned WHO failed. Do we know why? Can we learn from them?
It was bound to fail because the teams came in, stayed for a short period of time, provided a kind of training to master trainers, and went away. And those master trainers were not actually the people who were on the ground. They were government servants, somebody's favorite, and so on.
So coming back to what Bhushra and Faisal, you guys were saying, I think we have a number of models around one-stop shop, around DSD from other countries where this has been implemented for years and years at this point. And there are successful models already available that can easily be adapted to the Pakistani local situation. So conversation around these and available examples from around the world are very important to pursue. And with that, I will move on to the next question because we have a lot of questions in our chat and in our Q&A box. The next question is about the causes of the clusters that we've seen across the country in Pakistan. And the question is it needle reuse by providers, barber shops, or lack of sterilization in dental offices, or any other issues related to primary care or IV drug use that are the leading cause of these clusters in the country?
Dr. Faisal, or should I try? Can I?
No, I can try, and then maybe you can help me out. So between the three, a barbershop, dentist, and a reuse of needles within clinics, I think it's the last one, which is probably the main issue. And it may not always be reuse of needles, but it may also be just poor infection control practices. For example, often in these clinics, they have a big saline bag. They will use one injection and just keep sort of reusing it. And if that gets contaminated, then every time they do a flush, they're going to sort of reintroduce HIV into it. So and then now there are many reasons why this happens. Part of it is cost, part of this is training, part of this is a lack of places where they can dispose. So there are a lot of reasons linked up to it. It's not just lack of knowledge over here. And that's why IPC is not just sort of education. There's a lot of system change that goes on with it. But Dr. Omer, maybe you can help me out now.
What I have seen that these epidemics or outbreaks, it is not only the injection safety issues. Again and again, it's Ladkhana. And because I'm working since 2008, there's a huge number of MSM and MSW population in Ladkhana and Dadu. And there are a lot of transgenders. You look at the numbers in both in Ladkhana and Karachi also. So it's very complex. It's not 2 + 2 = 4. It's a bit complex. And then these, what I have seen in 2016, there's an epidemic after dialysis. And what I have noticed that these were chronic renal failure patients who have history of repeated blood transfusions. When I went to the blood banks, the screening was pathetic. And these were political driven. So we were unable to stop those blood banks. And actually IDUs were selling the blood and the screening was inadequate. It's a vicious cycle. So the whole health systems, what we are seeing is the outbreaks or epidemics small. It is just a reaction of some leakage. So we need to revamp the whole health system. Maybe Dr. Ramesh can respond.
So I see that We are well over our time, but I'll just take 2 more questions from Q&A, and thank you to all the panelists that have still stayed on the call with us. These 2 questions are a little more charged, but I did want to actually get to these questions before we end the session. The first one is, how is the CMU going to manage the program if Punjab is not going to share their data?
Can I or Dr. Ramesh? I've already planned and discussed with the CMU because Dr. Ramesh is here, and then his boss is a senior joint secretary. He has already talked to the program manager in Punjab, who is a medical doctor but DMG background, that Dr. Faisal Sultan, who is the federal minister, and the Punjab minister, Dr. Yasmin Rashid, we will arrange a webinar or virtual conference, or we should go to Lahore. But we have tried it every level from last 5 years. I'm a bit frustrated, but it is a ground reality. We are not getting out of 25 ART centers or clinics are in Punjab. And now after the UNDP arrangement, they are SR. So we don't have any power, anything to offer except the coordination. 18 amendment and this. So it is a chaos in health systems, but we are working, and I'm hopeful, inshallah, we will be successful. But Nashmia can add.
I think she had to jump off the call. Dr. Ramesh Kumar, are you still there?
Yes. I think Dr. Umair is very rightly pointed out and responded the query. As I already mentioned that we are on it, and hopefully we will get done, because we have involved higher management, even political leadership as well. So this problem will be resolved very soon. And the question is, very relevant, because without getting the proper data at national level, we can't do anything. Thank you very much. I think this is clear now, right?
Absolutely. Thank you both. And the last question that I'll take from our Q&A is about the fact that there is already drug-resistant HIV and drug-resistant TB in Pakistan. Don't you think it is a failure of the vertical program over decades? And how is the huge funding by the Global Fund justified, and would there be any accountability for that? And I know that's a very loaded question, but Dr. Bhushra, Dr. Umair, Dr. Ramesh, we will actually look forward to you guys to answer that.
I think Dr. Nashmi has left, she has to step down. Yes.
Yeah, I would like to respond to this one.
Sure.
So nobody has ever claimed that the programs are successful. HIV program has been an abject failure. So the sooner everyone accepts it, the better. You look at all the key performance indicators. So the figures which are submitted to the government are fabricated. So we are in a habit of fudging our figures, but the program, neither TB nor HIV have been successful. So there is a system of audit, and the Global Fund is actually quite worried because they are aware of the ground realities here. So they have put in a lot of checks and balances. And because of the poor performance of Pakistan in implementing the grant here and the poor results and the way the things are, Global Fund has imposed additional safeguard policy on Pakistan, which is actually imposed on countries where fraud is expected. So they are looking at us very, very closely. They're monitoring what the programs are doing. So there is accountability, and so the funds are being monitored.
Thank you for that. And Sama, back to you. I think we are well over our time that we had initially discussed.
I think thank you so much, and everybody have a blessed rest of the week for the 2021. And I hope we are COVID-free by next Yeah, inshallah, and looking forward to our next session in 2022. A very happy new year to everyone.
Thank you everyone for joining. Special thanks to Hamad and Saima, and Hina and Bhushra, Dr. Faisal, Dr. Umar, Dr. Ramesh, and everyone. And Happy New Year. And inshallah, we'll continue these talks the next year. Thank you very much.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you.
Great.